Hi, this is Dr. Bahrani. I'm doing my second vlog, my vlog number 2. Today we're going to be talking about the pre-op phacoemulsification assessment. I think this is a very important topic that most budding ophthalmologists would like to learn more about. And also, I think this is pretty important, especially for people who are just starting phacoemulsification. Categorize your surgeries in terms of congenital cataract, senile cataract, traumatic cataract, and pre-vitrectomy cataract. I mean, this is the way I classify those surgeries. Of course, in congenital cataract, you have to kind of think about the importance of measuring the axial length, making sure that there are no other pathologies, there are no PFV or persistent fetal vasculature, what previously known as primary hyperplastic primary vitreous, which is now PFV. Also, other things that may affect your operations, your results, capsule fibrosis, any of that issues. Also, you have to think about metabolic issues with congenital cataract, so you have to send for blood tests and things like that. The second thing is the senile cataract, which is the most common cataract that we encounter usually in the clinic. And this is pretty much a straightforward surgery. However, there are some things that you have to worry about before you attempt to do and operate on those cases. The third case is the traumatic cataract, and this is pretty advanced kind of cataract, and I would usually try to defer those cases if you're a new surgeon or if you are a resident. Of course, you have to defer this to a more senior specialist, especially since it may need some vitreoretinal intervention. Number 4, I'm sorry, is the pre-vitrectomy surgery. Sometimes in macular hole surgery, I do usually the phacoemulsification prior to vitrectomy surgery, or sometimes in cases where we have when we have vitreous hemorrhage, tractional retinal detachment, in complicated cases, I may opt to do phacoemulsification plus anti-VEGF injection. Then in a few days or a week time, I go ahead and do the vitrectomy case. So every case has a different planning. So in these cases where we do a pre-vitrectomy phacoemulsification, then I usually put a suture. I put suture in all incisions. So when I do the vitrectomy, especially when we do a lot of manipulation during vitrectomy, we may add a buckle. You don't want a collapse of the anterior chamber. So speaking about the categories, so the most important thing about starting phacoemulsification, doing phacosurgery, is to build your confidence. This is really important because if you start having a lot of complications early on, then this will affect, I'm not saying it will affect the final outcome, but it will delay your learning. So instead of learning how to do phaco in 6 months, you may end up taking a year or 2, because what happens is every time you get a complication, you have to live with this, and you have to kind of, have a sleepless night maybe because of that. So in order to minimize your complications, I recommend you use this mental notes and actually write those down in the notes before you proceed to surgery, or at least categorize it as an easy case, a straightforward case, a moderate case, an advanced case that you shouldn't be touching. So first thing is age. Doing a surgery, a phacoemulsification on a patient, a well-coherent patient who's 65 years old with cataract is different than doing a cataract surgery on a patient who's 85 years old with hearing loss, kyphosis. So all these things have to be kept in mind before you start. So age is important. A person, when I operate on a 20-year-old or 30-year-old is different than operating on a 65-year-old. Usually the patients who are above 55 are more likely to adhere to the instructions. However, below 40, you will have really difficult time telling them to sit still and not to move or not be apprehensive. So it is really important to have the age in mind. So let's say you put cataract, 3 plus nuclear sclerosis cataract, age 65, medical status, the patient having any medical issues, having any diabetes, heart disease, any other medical conditions such as kidney failure, kyphosis, anything that affects his positioning during surgery. Is the patient taking aspirin, not taking aspirin? Of course, we do operate on patients who are using aspirin, but you have to keep that in mind. Sometimes type of anesthesia affects the medical status of the patient does affect the type of anesthesia you do. Some patients are confident to do topical anesthesia, some are not, and they would like to do subtenon anesthesia or retrobulbar anesthesia or peribulbar anesthesia or general anesthesia for that matter. So the medical status affect your decision on what type of anesthesia you want to do. So that's number 2. Pupil size is also a very, very important point to put there. So what do we used to put? We said 5 to 6 millimeter pupil. It's important because you don't want to operate on a 3 millimeter pupil in your early career. You want to probably give that to a more experienced surgeon or your senior resident, because you probably need to use iris hook, myelin ring, or any things that may help you dilate that pupil, or you may just want to stretch that pupil with the wide hook and the Lester hook. But pupil size is important to write down. The presence or absence of pseudoexfoliation is extremely important. Pseudoexfoliation surgeries look easy, they look fine, but intraoperatively they behave totally different. And then I have many cases where I felt like I'm doing fine, I got the cataract out, and I'm ready to do the IA, and everything is going well, and then you'll hit a problem while doing the IA, or irrigation aspiration. So actually most of my trouble happens, pseudoexfoliation happens at the end when you're trying to do irrigation and aspiration, because that's when you get in trouble. You try to pull on the capsule, because the capsule is not as much as elastic as the normal capsule, and usually comes with the IA, and instead of maybe a few degrees of dialysis, you have 180 degrees of dialysis, and then you pretty much have to use a ring or any other sort of treatment plan that you have to come up with. So, talking about pseudoexfoliation, the grading is extremely important. So I find a lot of residents do not grade cataract accurately. So it's really important that you grade the cataract correctly, and you have to grade all the cataract. You don't, most people, 2 plus NS, 2 plus nuclear sclerosis, 3 plus nuclear sclerosis. Well, you have to put 3 plus nuclear sclerosis with a 2 plus anterior cortical cataract, 2 plus posterior subcapsular cataract, presence or absence of posterior polar cataract. You have to discuss and mention all these things in your surgery planning, because usually a cataract, sometimes you have a 2 plus nuclear sclerosis cataract, however you have a 3 plus cortical cataract. It's a totally different animal. It's a totally different surgery, because and also the planning of the surgery is different, because these patients the lens doesn't rotate in the back as a normal routine nuclear sclerosis cataract. So you may have to kind of do additional BSS viscodissection. So I mean, you really need to have to do more things to make sure that the cataract lens is more mobile in the bag before you start doing. My usual technique and my go-to-go technique is divide and conquer. So it's really important for me that I get a very good rotation of the lens before I proceed. The grading, also we talked about the presence of posterior polar cataract. That is very important, because the posterior polar cataract, you may have to refer that to a vitreoretinal surgeon or a more experienced cataract surgeon to make sure that you don't get a drop lens. Status of the patient: is he a monocular patient? Is he a binocular patient? I mean, early on in my residency, it was really, you shouldn't be doing a monocular cataract surgery on a patient who has one eye. I mean, monocular patient status is important to have those cases be done by a more senior ophthalmologist. Not even a person who just graduated. I think it has to be referred to a more senior ophthalmologist, because of the risk of complications, and you want to minimize the complication. The more the surgeon has experience, the less complications that patient may have. And the other issue that you need to also note: the presence or absence of any other eye conditions, such as macular degeneration, such as diabetic macular edema. All these things affect the status of the surgery. So you don't want to be doing a 3+ nucleosclerosis cataract on a patient with dry AMD or wet AMD, a patient who will complain post-operatively that they didn't benefit from your surgery. All these things will affect your confidence. And the reason for this video is you have to build your confidence. This is one of the most important things before. And oh well, you don't have to do the surgery. You'll get 2 other cases. But the important thing is that you're building the confidence. The more you do capsulotomies correctly, the more you hydrodissect the lens correctly, the more your confidence builds up, the more you can do a one case at a time without having your senior resident or your attending to step in. So building confidence is very and extremely important. And also we talked about the anesthesia. So we go again, I'm gonna repeat what I said. So you need to kind of put that in an age, medical status, aspirin use, no aspirin use, the status of the diabetes, controlled, not controlled, pupil size, very important, pseudo exfoliation, the grading of the cataract. If it's a mature cataract or a wide mature cataract, you probably want to send it to a different person. Monocular status, binocular status, and any presence of macular degeneration or any other retinal condition, or any other, such as uveitis. Those uveitis cases are very, very tough. Anyways, so this is the pre-op assessment of phaco. And one additional thing I forgot to mention: the globe and the orbital rim. This is very important. The nose, the orbital rim are extremely important things to note here also in your assessment, because patients who have high orbital rim, ridge, nose, you probably need to kind of do some type of positioning where you need to start thinking about that. You may want to go for retrobulbar surgery, so you can have more access, because the retrobulbar will lift the eye a little bit, and that will give you a little bit more access to the eye versus a more sunken eye. So all these things matter. The positioning before the surgery. I guess that's all I wanted to speak. Maybe I forgot some things, but happy I'm going to be doing another video. Happy if you can give me some feedback about this video, and what things you'd like me to discuss. I hope you find this video helpful, and please don't forget to subscribe, share, and like. Thank you very much. Bye-bye.